Yeah, don't talk about me while it's recording. Alright, so that's everything.
Yeah, they did. Put on there.
Arrows here.
Yeah.
Whenever y'all started, y'all can. Don't wait on us. I'm taking all kind of notes. So.
We're all here for you. Don't worry about it.
Okay, and Byron is here as well, so we're ready when you are.
All right. You tell us when you want us to start, when you feel that maybe they won't show, but we're okay if we go later or anything.
Okay, if you can just wait maybe 5 minutes.
Yeah, just feeling kind of good right now. Oh, and I'm sorry, Brianna, is that your name?
My name is Dina.
Dina, I'm sorry, Dina. This is Sam.
Hello.
I am in email jail, so I could not email out to you all of the packets that we're going to be talking about, but don't worry about it. I'll be discussing it. But it was sent to Cordella a couple of hours ago through some global thing, just to make sure that y'all had it. So if y'all at least want to get one copy of it, of all the attachments, y'all will get an idea of what I'm talking about. And then when you guys come to visit here, bring a flash drive with you, and we'll give you nice, pretty copies. It's just the folders are too big, and every time I tried to send them to you guys, it kept telling me that you couldn't accept it because they were too big.
Okay, I won't have Cordell, unless Cordell is going to pop up in this meeting. I don't even know how to get a hold of her right now to be able to get that for the meeting.
Okay. That's okay. We'll go without it, but
I'll get it from her after the meeting.
We'll overcome and adapt.
Okay, sounds good.
But just so you know, you will have all the documents that go with everything I'm talking about. If y'all bring a flash drive, I'll give y'all nice copies that you can actually do your own, adjust it however you want, or just throw it away. It's up to you.
No, that sounds great. Thank you so much. And actually, Danielle is here now, so y'all can get started.
Okay. Let's see here. We're going to talk about the Ryan White program. I'm Samantha Robinson. Most people call me Sam unless they're mad at me. I am here this morning with Melissa Anger. She is one of our case managers. I'm also a case manager, and we also have our new ADAP/intake/enrollment coordinator, and her name is Carrie Powell.
Okay.
We're going to talk about just the meat of what it means of Ryan White here, with as far as case management and getting people in and out and moving them through the system and getting them all the care they need. Okay?
Okay. Okay.
All right. So let me get started. Under the program overview, and I'm sorry you don't have documents, but let me just go quickly. Here, under we have an establishment to say who needs case management and who does not need case management. And the only way I can describe it is, think of the Ryan White program as a business. Case management is just one department of the business. Medication assistance is another department. Enrollments are another department. Physician visits are another department. Okay? So I'm just talking strictly right now about case management services. Not everybody who comes into Ryan White, because anybody under 500% of the federal poverty limit can qualify for Ryan White services. Okay? You will have to find out through Cordella and through your grant on how much over the federal poverty limit you're able to cover. I can tell you in the Galveston area here, we are only able to care for people up to 300% over the federal poverty limit. And that's established through the Magi and the Mock Magi. And we'll go into that later if you're not familiar with it. Okay? So under case management services, how a bill becomes a law here is anybody who needs assistance, we set them up with an intake appointment. From there, they get their intake completed. We'll go through enrollment documents in a little bit. Also, as part of that, they get an assessment from a case manager, and that from there is determined whether they need case management assistance or they do not. The people who fit in any of the criteria, which they are considered to be a special population, and those people are established by the state of Texas. They tell us who's a specialty population. For instance, as an example, it would be the homeless, the recently released from incarceration, anybody with CD4 counts below 200 or their viral load above 10,000. Anybody with untreated mental illness or substance abuse disorders, the newly diagnosed, new to antiretroviral therapy, people who
Okay.
have not been in care.
Can you, just a second to catch up?
Okay.
Recent incarceration, CD4 count of what?
CD4 count of below 200, and you know what? I promise you, as soon as I get out of email jail, I'm going to send you this stuff, and it's a flow chart, and it's very easy to read. So if you want to take notes or not, because I'm going to be giving out a lot of information, but I actually have all this in writing for you.
Yeah. If you're going to send it to us, then we're fine just listening.
And actually, Cardella already has it, but we'll send it again, plus give you more copies.
Okay, thank you.
Okay, so again, the people who meet criteria, which is an automatic that they can get case management services, okay? It doesn't mean that they have to accept it, because if you meet criteria, you will automatically be enrolled. That means we just going to pretty much pay your bill to be able to see infectious disease and take care of your HIV. It doesn't mean you get case management. Case management, you have to meet the criteria, or you have to specifically have a reason over and above on why you need a case manager. It used to be way back in the day, and this is as little as 2 years ago, everybody and their brother got case management, and we were pretty much their mother, their life coach, their everything through life. So you're going to find people who are coming into care or transferring from other areas, they're going to automatically ask, I need my case manager. I don't understand why I don't have a case manager. But the way that Ryan White overall throughout the United States is evolving is case management is to overcome barriers to care and to help people get acclimated to care if they're newly diagnosed or they have a special reason. But other than that, we are going through and making sure that their needs are taken care of in the beginning, and then we release them. And I'll get into that when we talk about the acuities. So we don't turn anybody down for care, and we can always put people on for at least 6 months just to get them through. But again, it's an automatic for a specialty population person to be able to access it. All right, so non-adherence to HIV medications along with unable to navigate the system of care due to language. I have several people here in Galveston, either they're illiterate, they cannot read, so it's an automatic, we keep them on case management purposes, or we also have English as a second language for several people, and again, their care is very time consuming, so that's why we keep them on case management. Okay, other than that, I have a flow chart just so you're aware, and it's kind of like it leads you in other directions. When you have people that all they need is for us to pay their bills and they need to ask you a question once in a while, we're already paying their insurance or whatever it is. There's another criteria, and it's called non-case management linkage to care. Okay, and I'll go into that in a little bit, but that means when we're doing our documenting and we're actually helping them, we're giving them one-time help. Okay, like we're helping them, okay, you go here to go to the dentist or you go here to go to the eye doctor, but it's not necessarily where you have to case manage them and be their life coach. Okay, that's with that, we talked about specialty populations. The state of Texas, again, establishes the specialty populations on a yearly basis, and they can change it at any given time. The one thing that you're not going to find is listed under a specialty population, and this was a very big point of contention when we met at the state level, was transgenders are not considered a specialty population in the eyes of Texas. Now, I can speak for Houston and I can speak from here in Galveston, at the local level, we have established that a specialty population is transgenders also, so it's an automatic where we offer them case management services.
Okay.
Okay, but again, it is not listed under the state. Okay, the next thing we're going to talk about is requirements for assistance. When you come in and get your intake, what happens is you have to establish what your federal poverty level is. That's like any other assistance you're receiving from the government. There's two different forms. One is a MAGI and one is called the MAC MAGI. And your intake coordinator is going to have to complete that with every client that gets care. We can accept people based on how much money we're getting under our grant up to 300% over the federal poverty limit. Over and above that, we can get waivers for up to 500%, but anyone who makes over 500%, and on average, say for a single person, I believe that might be approximately about 50 to 60,000. But again, it's a calculator that we use, and it's established by the federal government, and it comes out every November time frame telling us how we need to do it. So you're also going to get copies of the calculator.
Okay.
Cut and dry, establish what it is you're looking at any income for that person. If they are unmarried, it would be them and any other people that fall, it would be their income. If they are married, even if they present themselves as common law, they are considered to be married, and they are required to present also their spouse's documents. And what they go on is you have to have the last month of any income. That includes SSI, SSDI. The only thing it does not include is SNAP benefits, or if you're receiving child support. But if you're receiving alimony, it is included.
Unless child support is your only means
Of income. There you go. So anyway, it's established. It's only good until the next review is done in 6 months, or if something in their situation changes, because we are required to inform people we are the payer of last resort. So if their situation changes, such as they either get a job and now they're making more money, or they lose their job, so now they have no income, they're supposed to report it to us. But technically, the only time we're checking again is 6 months later.
Okay.
Okay. How we may differ from you, and I don't know what your grant is going to cover. We cover things such as outpatient ambulatory health care, which is strictly our doctor's visits. And it's also over and above some of our case management, those non-medical people that we're helping, you know, doing one-time thing, helping navigate through applying for Medicaid or whatnot. That's where that billing occurs. Medical case management is over and above where most of our money goes to. So it's a high need. And you'll see when we do when we talk about reassessments and assessments, medical case management plays a big part in it. But again, we're evolving to where more people are coming off of case management after a certain date. It's not like any in the past where we kept them on forever and managed them. The next thing is local aids pharmaceutical assistance. That are all medications. There's a formulary, and you hopefully have gotten a copy of it already. But local aids pharmaceutical assistance is actually a formulary that's established on medications that are approved that we can help people with. So if they're in our program, over and above, it does not include HIV medications, but there is a formulary. I know in my offices it's posted in the doctor's office, and we have copies everywhere. So we know automatically, as long as the person is signed up, say they need a pain medication or fluconazole. Nope, not even fluconazole. I'm sorry, let's use fluconazole for a short-term duration, okay? They need a short-term antibiotic or prednisone.
Yeah.
That is all on the formulary. That means automatically if they qualify for our services, I don't have to hunt around trying to get them medication. I can refer them to the LPAP and it is covered under the LPAP. So whatever pharmacy you're going to be contracted with, whether it's internal or external, you're going to be able to get your clients' medications. There's some things that are not on the formulary, and we'll talk about that with, in a little bit. When it's not on the formulary, either it's an HIV medication or it is going to be a medicine that is very expensive, say for Hep C, or it's going to be like Restasis, you know, one of these very high-cost drugs. For the most part, these drugs are all our common $4 medications pretty much. But it is very comprehensive. I would say at least 90% of our patients' drugs are found on the LPAP. It's the others that we have to get PAPs for. Okay. In addition to that, under our needs and risks and our service usage, we also cover mental health. We are contracted here with a psychiatrist. And again, this is only how it's working here in Galveston. You'll have to set up your own process. But we have a psychiatrist that comes to our clinic once a week, and we just have him one patient after another. And again, if we are incurring the cost of that physician visit, they have to be signed up with Ryan White Services. We also have case managers that work clinic on any given day. So not only do you have your own patient load, but you're assigned a clinic day. So as doctors are in clinic and our patients come up, because we track our patients on who's in clinic on any given day, we're actually following behind them and taking care of any immediate needs the doctor may have. The next thing is, and I'm sorry, for this next year, we've also added more money. We just had our priorities and allocation meeting, and we've added more money. So we're going to, with the new grant, as of April 1st, we're going to be adding on counseling services. So we're looking at contracting with an outside agency to provide counseling. The next is health insurance premiums. Health insurance premiums, more and more, it used to be there was only Ryan White, so you had Ryan White, but since the Affordable Care Act came into play, anyone in the state of Texas who we're not a Medicaid expansion state, so if you are over 100% over the federal poverty limit, you qualify for us to provide health insurance premium assistance. Okay? Unless it's a special situation where you qualify, say you're a newly diagnosed person, so you have a qualifying event, right, which would get you outside of the open sign-up time. The sign-ups will begin, I know this past year, I believe it was about November 15th, and that was starting on January 1st. So people say somebody's been in and they've only been Ryan White for the longest time, but now they just got a job and they're making over $1,000 a month because it's right. Federal poverty limit for a single person with no dependents would be at 100 percentile would be right at about $1,000 a month. So thinking if somebody got a job and they're making over $1,000 a month, that's now a qualifying event at any way possible. I will always, as a case manager, try to get them the Affordable Care Act insurance. And again, it's a separate department from case management, but me as their case manager, I'm helping them navigate through the system. Once I graduate them off of case management, it's only going to be their health insurance premiums that are working for them. But again, it's a separate, it's still billing on Ryan White, so I'm required to keep a chart for them, and I'm required to do intakes and monitor them to make sure that they're complying with our program. And the last but not least is for our service use is our medical transportation. Medical transportation. There are service definitions that I'm going to provide for you guys. but medical transportation has a lot of limitations and restrictions, but what it is in your service area, there should be, whether you're contracting out for it or you're going to have an internal, it's up to you. It guides you, and you have the ability to pay for all physician appointments and your case management appointments. Anything that's considered medical, as long as they provide, you're able to establish that they do have a legitimate appointment, you're able to pay for those appointments, for transportation to get them back and forth throughout your service area. And I'm assuming that you guys cover multiple counties?
Yes, ma'am, we do.
Okay. For our area, we cover Matagorda County, Brazoria County, and Galveston County. So I have the ability, we have contracts with several different private companies to provide transportation for this, for them, to their appointments, to bring them in here to UTMB if possible. What else on that? Under medical transportation, I know for us, and everybody is different, it just depends on what your contract is going to say, but for us, we have to give them 7 days notice.
Okay.
Okay, that's pretty much the only limitation is the 7-day notice criteria, and then when we're organizing it, someone else under that handling medical transportation is actually doing all the booking and everything else. As a case manager, the only thing you're really looking at is, does my patient have transportation? Have I sent the referral off to get him transportation? Okay, and one thing that is new that we're all going to have coming as of April 1st, because that is the new grant year for us, is emergency financial assistance. Every area uses their emergency financial assistance differently. We have never had it before, but we are separating our emergency financial assistance from the LPAP. LPAP is local area pharmaceutical assistance, that pharmacy I talked about, to actually just what it says, emergency financial assistance. That's our little checkbook under case management. If you have a patient, say they're out of food and you can't get them any food, we can actually get them a gift card for Kroger and provide them with some groceries. Or say, I know there's one, I don't know if it's Nacogdoches or one of the other areas in East Texas, but they use their full emergency financial assistance to help people get glasses because they don't have anybody to do vision for them. So it's going to be totally up to you. I do know there's a limitation per patient of $800 a year that you're allowed to pay each client. But again, most of our money goes to LPAP, which LPAP, when a person has ADAP, and we'll talk about ADAP in a little bit, when a person has ADAP, the requirement, as long as you're using your designated pharmacy and it's under 340B, there's only a $5 copay, okay? Well, under the law now, under LPAP, because it's an HIV medication, we're not able to cover that $5 copay. So how we've gotten around that is you designate a certain amount of money into your emergency financial assistance, and that is what that $5 copay is going to be covered under. So we're still able to help the patient because I'm sure if you're a case manager, you're going to know some people claim they don't even have $5 to their name, and that's going to be a barrier for them to starting and continuing their medications on a monthly basis. So again, it's covered, but whenever it comes to HIV medications, long-term medications, it is covered that any copays involved, or if you had to get something in an emergency, it's covered under the emergency financial assistance. Okay, standards of care. They are everything we're going to talk about today under standards of care.
Can we back up for just a second? Lala has a question. That emergency financial assistance, is that the same across the board? So for everyone, like you guys will get $1,000 and we'll get $1,000, whatever it is.
What happens is in your area, there was a priorities and allocation meeting within the last couple of weeks. I can tell you mine was last Friday, and I'm not allowed to vote because I'm considered to have a conflict of interest. But members of the community, along with consumers for the area, are all come together, and we talk about what the budget was last year and how much the budget is this year. And again, the budget is established because members of the community, which are mostly consumers, our HIV clients, actually sit there and they vote on who gets how much money. So because the emergency financial assistance is brand new to us, and we know that we can no longer purchase any HIV medicine under the LPAP, that therefore all we did this year was we cut the LPAP in half, and we put half of it in emergency financial assistance. There is a possibility whoever's going to be managing your grant will be able to move funds back and forth.
And that'll be at our discretion, correct?
Yes. What we did is because we are not the only provider here for our area. So we know we got, say for instance, $50,000, okay? So what we determined last week was we took $25,000 and we moved it into emergency financial assistance. But since we're not the only provider, we had to split that amount with the other organization, because me as a case manager, I was fighting for my section under case management. I didn't want the person or the organization that handles the LPAP to get all of the money, because then I would lose total control, and I didn't think I could help my patients like I could. So behind the scenes, we negotiated with them. We're getting $2,500 MAD money just for case management to help emergently. For any expensive stuff, we're still going to send that to the LPAP and emergency financial people, because again, they're still going to have $25,000 sitting in their account, or $23,000. But I want it to be established for my section under case management. I specifically am able to bring out vouchers and to speed up care, not have to go through a whole nother barrier to get care.
Right.
So you're going to have that flexibility. I believe in your first year, it's going to be told to you exactly how much money y'all are getting and then how it's going to be divided up. But Cordella would be able to tell you more, along with the people from TRG. And then next year, under your priorities and allocations, it'll happen just like I talked about. You'll be able to talk about your program and what you're asking for, you know, because you're there fighting for your money kind of thing. But ultimately, it becomes to everyone who does not have a conflict of interest, are the only ones who are able to vote to say, you have this X amount of money, where is it going to go to, in which department or which pile. Okay, everybody, everything we talk about today is actually guidelines we receive here at UTMB. We receive money under Part B, Part C, and Part D. Everyone is different. Again, your service area, you're going to be told on what part money you're getting your money from. Part B are strictly physician visits and things that fall under the oversight of the state of Texas. So they send us our guidelines, and from there we get our service standards and our universal standards, okay? And I promise you, you will get copies of all of this. So this is going to kind of be your Bible to help guide your practice on what you can do, what you can't do, what your limitations are, and what they're not. It breaks it down. Universal is the program as a whole, and then we also have case management standards. Right now, they're under review at the state of Texas. The legislature is in session, and they've updated them this year. Were you on, was anyone on the call that we had this past Monday? I do know Cordella was on the call.
We didn't, yeah, Cordella would have been in.
Okay. On the call on Monday, we were given notice to say, update your policies and procedures regarding the new standards coming out. I myself, and it's only for me, Sam, I don't feel it's appropriate because they've asked for comment through the state of Texas, and the comment time is over, but they have not finalized our new standards of care. So we are still going by 2016 standards of care until we get notice from the state that we are finalized. From that point, that's when we have to go in and we have to update all of our policies and procedures to reflect any new requirements or any changes. For the most part now, everything that you're going to be sent and you're going to get copies of, it's all reflected. We are meeting the standards of all of the care that's needed to be provided under the grant. Part C covers case management and any other extras that are needed. That's kind of like the general pot that you can't cover under doctor and physician visits, but Part C is pretty much case management you're billing on. Now, we have Part D. Not everyone has Part D, and not everyone has Part A. We do not have Part A. Part A is federal money that is only given to big metropolitan areas. So I do know in the state of Texas, it is being given, Part A money is being given to Houston, Austin, and San Antonio. And I believe maybe Dallas, but I'm not sure.
Yeah, we talked about that at the conference.
So that is strictly Part A. We are not allowed to get any Part A money. We're considered rural. Part D is women and children is considered to be 24 and under. So anything we do for anybody who is a woman or 24 and under, whether they're male or female, we have to bill under Part D. And again, as a case manager, it makes no difference. You're just taking care of your patients. When it comes to doing all of your billing and writing, to typing everything into Aries, Aries is the program that we're reporting where we're spending all the money at. When we do that, we have to bill under the appropriate part, B, C, or D. That's when it's important for you to know. Here at UTMB, we're set up a little bit differently than other areas. In other areas, I do know of case managers go into Aries, the program, and they're doing their own billing. We have actually set aside a certain portion of our funds, and we have a data entry person. So our electronic medical record here at UTMB is called Epic. So we document everything in Epic, and then we keep a log on the side. And we write down, we wrote a note on this client in Epic. And all short and sweet, it's just a spreadsheet stating who the patient is, what their medical record number is, and did we put a note in Epic? Because again, if a note is not done, it's not done, okay? So we turn in our logs on a weekly basis to our data entry person, and she puts everything into Aries. Aries is Aries is the electronic record that we report everything to the state of Texas. It is not user-friendly whatsoever. It's very time-consuming, and it would slow us down in our work if we had to do that. But, for instance, Texas Children's, they're also a UT hospital, and they also use Epic, but they require their case managers there to do their own documenting. So the Epic does not interface with Aries, so unfortunately they have to document everything in Epic, and then they have to do it over again into Aries, because every little thing you do gets billed. Say you spend an hour with your patient and you're allocating, say, an hour. What your billing person is doing, or what you're doing when you're documenting in Aries, is you're breaking down all of that time. 10 minutes you did education, 10 minutes you discuss medications, 10 minutes you help them with doctor's appointments. So it all gets broken down in Aries, and that's how it has to be billed. Are we on the same page?
Yes, Sam.
Okay.
I guess be completely mindful of time and how you're and what you're doing.
Yes.
Which I'm sure now it just comes natural to you, but for us, documenting minute by minute or anything we did is very foreign.
in your note itself, say you're doing, if your Aries does not interface with your electronic medical record, I'm assuming, are y'all going to be doing hard copy charts or electronic medical record?
Hopefully eClinical.
Okay.
That's the plan. Last we were let in on the plan.
I'm the team leader here at UTMB, and I can tell you the way Melissa is relatively new, and so is Carrie, and the way I kind of describe it to them is we're nurses here, okay? Carrie is she's in the medical field. She's not an RN, but she's in the medical field. And the way I describe it to them, because it was totally foreign to them too, and to me coming into this, is you take care of your patient like you should, and you just be mindful of your time, and you will catch on overall on how much time you're actually spending, but you got to take everything into account. And then when you're doing Aries, you're actually breaking it down, and if you need to, you go back and adjust your time, because again, it's 10 minutes here, 10 minutes there, and under all of these requirements, under the service standards and whatnot, we have to touch all these things because that's what we get audited on. So you go back in if after the fact and you say, okay, if I did all this today, even though I was only there 30 minutes with him, when I did my billing, it came out to a significant amount of time. I go back in and I say, no, I actually spent an hour because that was only with the patient sitting in front of me, but I did a lot of things behind the scenes, like I was making phone calls and whatnot. It'll all match up in the end, but it is going to be time consuming for you. Ryan White is not easy. Okay, we're going to go to enrollments now. And again, just stop me if y'all have any more questions, okay? All right, okay. Under enrollments, it's a relatively new position for us, and we've had to carve out our own job here because in the past, all we had were case managers, and we were doing everything for Ryan White, okay? So Carrie's actually only been with us 2 months, and we're still learning our way, and what I'm telling you now may not be what we're doing in a couple of weeks because we're still finding our way to determine what's working for us and what is not. Enrollments came up. An enrollment intake person came about because in the state of Texas, under the Medication Assistance Program, ADAP, unfortunately, there were so many errors involved with that program that now the funding is actually coming from that program to create an enrollment worker. And it's actually an ADAP worker, but they've added enrollments to it because they don't consider ADAP would take up 100% of that person's full FTE. Now, they go hand in hand with each other because in order for you to complete the ADAP application with the patient, you need all of their proof and documents. So that's where enrollments come into play. So it's like a 4-page form that she completes with them. Again, it's all electronic, and it covers demographics, the proofs. Proofs are proof of identity, and again, it cannot be expired. And I have copies of you exactly what is recognized as a legal proof for the patient. The one thing we can't accept is anything that's fluid. For instance, if they have a cell phone, there's no guarantee that they live at that address because cell phones are going everywhere. So unfortunately, they will not accept, say, a cell phone bill as a proof. But what we're looking at is proof of identity, proof of residency, and proof of income. That's what establishes you to be able to become a Ryan White client. Again, the Magi and the mock Magi are the forms that establish what you are over the federal poverty limit. That's why the proof of income. It is required for every patient that we are possibly going to spend any money on at all, or if they're going to possibly get ADAP. The difference between a Magi and a mock Magi, the only difference is with a Magi is that person provided their tax refund. So we're getting the number strictly off their tax refund. A mock Magi is they're just bringing in their pay stubs or SSI or anything else, and we're creating it ourselves. The next thing that's required is an IRS 4506T. That's a document required by the federal government because they don't necessarily believe anymore when people bring in their tax forms that that's the actual tax form that was submitted. So IRS 4506T is the document. It's a verification that they did their taxes, and this is how much was on it, or they did not file taxes whatsoever. There's also a line on there to verify. As of right now, until June 15th, we are still asking for taxes when we sign people up for 2015. After June 15th is when we have to switch over and we start asking people for their tax documents for 2016. But June 15th is the cutoff date. I know here we send off so many IRS 4506Ts. I have to kind of fool the system when I send them off because they think I'm a fraud and usually stealing people's identity because I constantly ask for them. So I will get rejection letters saying, we've sent, regarding this client, we've sent a letter to that person. If you want more information, please let us know. Sometimes they will send the form to us, and then most of the time we get the rejection letter. Under the requirements for our grant, the only requirement is we make that request. So if you get the rejection letter, it's still okay, but we've made the request, we've met the intent. Okay, we'll talk about ADAP and or PAPS, but this is also just to streamline our process. This is done at the enrollment time frame. According to when the patient is giving us information, they tell us, I don't have a job, I don't have any money, I don't have insurance, I don't have any way to get medication, we already set up that ADAP for them. So the first time they see the doctor, they're getting labs, and we're not having to wait for the patient to come back for their second visit a month later to tell us what medicine they're on. We are talking with the doctors for that ADAP application. We're talking with the doctors as soon as we're getting information back saying, what kind of medicine do you want them on? Because we've got that ADAP application completed and we're working on it. It just will decrease the time that we're waiting. And I'll get into ADAP later, but there's a time frame. There's a difference between expedited and then our regular clients, and it strictly goes on what your CD4 count is. The initial appointments are also made at the enrollment time frame. So our intake person, along with the case manager, we work hand in hand with each other when we're doing an intake. Technically, the standards are a case manager must meet with a person. Even though they're enrolled, we can get things rolling, but a case manager must meet with them within 2 weeks. We've established to where we are doing it all on the same day to make sure that that patient is covered and we're getting them what their needs are on that first day. So depending on who it is, whether it's the enrollment worker or the case manager, we're establishing all the initial appointments. We're giving them the referrals based on what their needs are. We're setting up the first doctor appointment. If it turns out, say they for instance, they tell us, I think I might have an STD, and then of course we're drilling down and asking, well, what are your symptoms? Do you have a rash on your hand? Do you have a drip? You know, whatnot. It could be where we're asking the doctor to intervene on that day and see them that day. For the most part, if they don't need any urgent need for an immediate doctor appointment, we will get them the first available appointment. And there is criteria on how soon you have to have a doctor's appointment for someone. And it's established at any given place, but I believe for us it's within 1 month or 2 months. But again, we try as soon as possible to get people in. We have more than one clinic, so we're able to accommodate people in the time frames. Again, during enrollment, we give referrals. One place we refer to is called ACCT, Access Care of Coastal Texas is what it stands for. They were our subcontractor this year for medical transportation and for the LPAPs. So we got the grant, and then we actually handed that money over to them, and they manage those things. It may or may not be different for you. This next grant year, we're separating the grant, so we're not even going to have LPAP money or transportation. All they're going to be is a referral agency for us. So it'll be an automatic, just for the fact that if I know somebody's going to need a ride, from the enrollment date, I'm going to set up a referral for them to go to ACCT and get their intake done. Because again, on their side, if they need to use services, they have to sign up with them because they've got to maintain a record for that client too. Any questions over enrollments?
Not so far.
Enrollments are good for 6 months. So after 6 months, you're going to have to re-enroll your client. That means they've got to prove their eligibility. If they don't have a case manager, if they don't have needs, anything like that, all they're doing is meeting with that enrollment worker. But if they meet any criteria where it's like, I need this and I need that and I haven't seen my doctor, it's an automatic, it gets kicked over to as a referral to the case manager to where we need to do a reassessment to see if they need help or if it's just one-time thing. Okay, so that covers enrollments. Under education, every patient, under the criteria, we're required to provide certain education. So we give to every client who comes in a general education packet. It covers everything, just as if it pretty much hits the highlights. Anybody who's afflicted with HIV, it's how did I get this? How do I tell my friends and family? What do I do about safe sex? What happens if I have a negative partner? What are the risks involved? How do I get labs? What do labs mean? What does a CD4 mean? What does a viral load mean? The best website there is where we get our educational packets from is, it's called www.aidsinfonet.org. So again, we cover everything, and when we were audited last year, they were very happy with our educational packet, because as long as I write in my notes that I provided the educational packet, and I keep packets for everybody coming in that needs it, they gave me credit. So I didn't necessarily have to write, I educated on this and this and this and this, instead of did a full breakdown. It's just I gave them the general education packet. In addition to that, when the case manager is doing their assessment, it's not added to my general education packet, but when the case manager is doing their assessment and say it's triggered because one of the questions we ask, are you a smoker? I'm giving them education on quitting smoking. If they say, I'm on medication and I haven't taken it in a while, then I'm giving them medication education. If they have hepatitis, I give them pointed stuff saying, okay, this is what happens when you drink alcohol and you take your meds and you have hepatitis. And that's for hepatitis A, B, or C. And then we also have things that are specific for women. That's their annual PAPs, pregnancy info, the higher risk of cervical cancer. And so the information you see on the left side on the right side, is more pointed toward if it's applicable to the patient, but we do have it available. Education is really big. When you're doing your notes and you're getting audited, they're going to be looking for education. So just make sure you hit that hard. Okay, in addition to that, when clients are started on medication, I have information sheets specific to the drug that we're giving them. So not only is it in their general education packet, and it just gives you a general overview of all the medications available and how you should take it, what are the most common side effects. When they get started on medication, I provide with the client the actual document stating what the medicine is all about. We have found over time, unfortunately, if we give them information, word of mouth, and it's kind of like HIV is a small world. They'll say, can I have this drug or can I have that drug? So we don't give them that until the doctor actually orders it, because not every medication is right for every patient. Questions under education?
Do you, whenever we come to visit you guys, we'll look at the aidsinfonet.org, but do you have like a little thing you could give us, like a little
Yeah, I'm going to give you all this, and actually Cordella's already got them, but I'll give them all to you. And you'll be able to establish your own practice, because what it is when you go to that website, it's like the national site for AIDS information. All of the documents that we have, information sheets, they're all numbered, like 501, 502, 503. You can actually go in, and when you're looking at the information sheet, it refers you to other documents, like one is just an overview of hepatitis, but then in the document itself, it'll say, if you want more information on Hep C, go to document 501, so you can print that too. Okay. Or if you want Hep B, would be 502, things like that. Okay. So yes, you'll get all of this, I promise. None of this is secrets. We'll be happy to share with you.
Okay. Thank you.
Under case management assessments and reassessments, this is where it is triggered when the enrollment person has done her enrollment for a new person. We are required to do a comprehensive assessment at the initial visit. Going back to when I first spoke about people the vulnerable populations and specialty populations, it's an automatic, I'm going to do an assessment on every one of those people. For the people who come in and they've had HIV for 20 years and all they want me to do is pay their bill, if they don't want a case manager and they indicate to the enrollment worker they don't want a case manager, I don't have anything to do with them. I'm only there if they need me and if they want me. But I can tell you as standard practice here, we do a comprehensive assessment on everybody to determine what their baseline is and what they're going to need. So under this, under the stipulation with the grant and the standards of care, this is all the components that comprise the comprehensive assessment at the initial visit. You're required to do a mental health assessment as a case manager on everybody, and it doesn't determine which one you use, but we use the SAMIS scale. So we'll give you that scale if you want to use it. Otherwise, there are other ones out there that you can use. It's just the easiest one for us. It's just clicking the box. What that mental health assessment does, it determines mental health risks involved, and then it triggers you on if you need a referral to send them to psych. Like it'll ask you questions about, over the last 3 months, have you been feeling down, so much that you couldn't go to work or whatnot? Or do you smoke any marijuana, or it asks different questions. It's general questions, but it leads you to say, do they have a substance abuse problem? Do they have a mental health issue? Or I think that's pretty much it. And it tells you automatically they need a referral if they're positive for any of the indicators. In addition to that, you need a nutritional assessment. It goes both ways. When people come in, if they've had the condition for a long time, unfortunately, the biggest thing involved, you're going to see these people with wasting. So those people may need a dietitian, they may need an intervention right away to where they get a PAP, and we're providing them with nutritional supplements to help put weight back on them. On the other hand, if these people, we're also monitoring them, because if they're a new diagnosis and we put them on medication, it's not unheard of where, unfortunately, people will gain as much as 100 pounds on this medication. So it goes both ways, and you're doing nutritional assessments on people. One of the things I know as a case manager, I'm looking at my clients' weights every time that they come in, because you never know which way it's going to go. And then part of the grant is you have to have a dietitian as part of your contract that you're able to refer people to if needed. Also, you have to have the ability to provide nutritional supplements, and the nutritional supplements for us are covered under the LPAP. So all we have to do is provide a prescription for the people who need nutritional supplements, and they're given a case at a time. Quality of life, there's questions in there that discusses quality of life, such as have you been too upset to go to work, or how much have you been focused that you're so upset over your HIV. Psychosocial, that goes hand in hand with quality of life. You're asking people questions such as their history of abuse. You're asking if they've been a perpetrator, if they've been in dysfunctional relationships, We're also asking questions as far as how do they identify. Do they identify as male, female, transgender, asexual, whatever it is, this is how they identify. And this stuff, you will notice as you're doing your documents, I know if you follow the documents that we're using and we're going to provide them to you, it goes line by line on how you're documenting into Aries. So you're getting all these questions and Aries is asking you all these questions. So you have every answer. All you're doing is plugging it from one form to another. Okay, so we also talk about functional status and quality of life, behavior risks. One of the questions that we're required to ask, we do get into their business and we ask them, one of the things is how many partners they've had. I believe it's in the last 3 months. It used to shock me when people would tell me there was 30 to 100, unfortunately, partners, but you will see it. So we do ask those questions. We also ask about substance abuse. I do know here in the Galveston area, it's an automatic trigger where we will offer them either inpatient or outpatient rehab if it's a positive that they're on any other drugs besides marijuana. We use the Gulf Coast Center for our substance abuse counseling, and anymore when someone is smoking marijuana, as long as they're not doing it in other forms, you know, adding it to crack pipes or whatever, then they don't consider that to be a rehabable thing. The next is the acuity scale. The acuity scale is the determinant that decides whether a person is case managed or not case managed, unless it's one of those specialty clients or they're asking you, please put me under case management. Even though they may not meet the trigger under the acuity scale for it, you are allowed to put them for 6 months and then you can graduate them as needed. But again, we cannot deny anybody case management services. The specialty population and the acuity scale guides us to tell us who we're supposed to case manage. Okay, everyone who is case managed, we require a care plan. And the care plan, they're very much, when you get audited, they're sticklers on it. The care plan has just recently changed where it was very much more comprehensive. Now they brought it back to basic. So based on your acuity scale, whatever the highest needs are that triggers that they need a case manager, you're going to take the top 3 things and establish a care plan for them. So it's going to be based on needs and goal. What it is, it's basic. So say the person has no transportation. So you're in turn, they have a problem, they can't get to their appointments because they don't have transportation. That is one of the things under the acuity. They don't have regular transportation. So what you're going to do, if that's one of their highest 3 needs, you're going to establish it under the care plan to say, I'm going to provide them a referral. They have no transportation is their need. So your goal is provide them with a referral to your referring source to get transportation. And then your job as the case manager, based on the acuity, is how often you have to touch base with them to tell them, you need this, or you need that, or did you follow up with this, or did you follow up with that, or let me tell you what I did for you. It's strictly based on the acuity, so your care plan. You do no more than 3 at a time because it's been determined by the state that it's too overwhelming for our clients to have any more than 3 goals at a time that they have to work on. But the whole goal behind this care plan is getting them through the spectrum of care and getting them established and navigate through it so we can take them off of case management. So they are only considered to be open clients then. The other forms,
I'm sorry, this is Cordella. How are you?
Oh, good. Thanks for joining us.
I'm sorry I was late. I had another meeting that fell in between this and the other one. But regarding history of abuse, for those with domestic violence, sometimes it's not a history but a current situation with domestic violence. How do you address those?
That's where case management comes in, and we have to provide resources for them. we've gone as far, we have that situation here periodically, and we've gone as far as say the abuser, the accused abuser is sitting out in the lobby, we'll isolate the patient from them, and then we actually will offer the person resources. So one of the things is just basic case management as a social worker. You're doing a lot of social work in this case to where we'll do immediate interventions if the patient is amendable to it.
Okay.
Or if it's just a history, then we have the ability, say, under the mental health part, if they're having a hard time dealing with it, because that's when we're doing that mental health assessment, if they are having a hard time dealing with it, then we can, that's one of our criteria to say, okay, do they need counseling or do they need the psychiatrist?
Right. Okay.
So all of it kind of guides you based on all the questions and you're asking on which direction you need to go and how immediate you need to be. And I'll get in more in depth in the acuity scale in just a little bit. Referral tracking, you need it to keep yourself organized as referral tracking because we work as a team, as a group. So we need to know at any given time, say you're, you know, here at UTMB, we are assigned our own patients, but at any given time, anybody should be able to step in and help that client, especially the case manager, right? So if I'm not available that day, my notes should accurately reflect where I am with that patient versus where am I with providing referrals, where am I on what I did, why did I call them and leave them a message. So anybody can pick up on any given day on what that client has done. Let's see here, the next is needs assessment. So based on when I'm doing my assessment as a case manager, I have a certain document and it's kind of like my checklist. Did I take care of them for ADAP? When do I expect their ADAP to come back? It's me, just my flow sheet saying I sent it off this day and I anticipate they're going to get it back this day. Do I need to send them to the dentist, right? Everybody gets sent to the dentist. So I anticipate I've already referred them. It's part of the care plan. That's one of their highest needs, good oral care. So I've given them the information on this day. I anticipate as a case manager that they're going to have their appointment on a given day. And then there's also a point where I say it's closed out because they completed it for the year. The next is targeted education. If they come in and say, you know what, I left my medicine, I lost my medicine, I don't know, I have a stomach ache, I don't know if I'm supposed to take it on any given day or take it with milk or whatever, then I give more targeted information and education then too. So education plays a big part in it. The other thing, part of it, when people are case managed, they're reassessed at 6-month intervals, and I do have those documents for you guys, and Cordella's already been sent, but we have 2 different packets because we are also in the paper world, so we have a hard copy chart for the client. So you have all of those documents, but we do a little bit different. For the most part, the comprehensive reassessment is the same, but we're asking more pointed information as far as like, has there been any address changes? Has there been any phone changes? Is there any significant in your life where you want to change your emergency person? Things like that. But they're always at a minimum, if you're case management, you require a reassessment every 6 months. Now, the follow-ups are completed as indicated by your acuity scale. Your acuity scale is determined. So when you're looking at all the needs, it's like a 3-page paper, and you're clicking the boxes, and it's under different things like do they need transportation? Do they have a problem with substance abuse? Do they have a problem where they've been out of care for over 6 months? So they're asking you all these questions on the acuity scale, and you're grading it 0 to 4. 0 being there's no problem, they're doing everything independently. 4 means they are in crisis right now. So based on that, you've after your 3.5 pages of just clicking boxes, and it is quick and easy, I promise you, it's less than a minute to determine this. That's where you determine 0 through 9 is case management is not indicated. Here at UTMB, we call them open patients, meaning all we're doing is paying their bills. okay? If they code out as a 10 to 18, that means they're going to be a basic case manage. That means they get a case manager. Under basic case management, we have to contact them at a minimum of every 90 days. And again, all this is writing, so you don't have to necessarily take notes. It's on the acuity scale itself. A minimum contact every 90 days to reassess the acuity. We don't have to do that comprehensive reassessment. Here, when we're doing our documentation, we just call it a follow-up. We're saying at 90 days, I've got to follow up. No more than 90 days, I've got to follow up with my patient to see where they're going with all those care plan goals that I've given them. Did they go to the dentist? Did they sign up for transportation? Did they come to the doctor? Things like that. So I'm touching base with them. Every time you're in contact with them and you're working with goals, you're also updating your care plan. It also talks about you have to document in areas, so we're taking credit for that follow-up visit. Every time you are putting your hands on that patient in any way, whether it's through correspondence, through a phone call, a face-to-face visit, whatever, you are actually doing a note and you're billing for that time. And then also, again, documentation. So if they're a 10 to 18, they get basic case management. A moderate would be an acuity scale of 19 to 36. 19 to 36 means they have a case manager. You have to be in contact with them at a minimum of every 60 days. You have to do notes in areas. You have to update the care plan. And again, you have to make sure your documentation is accurately reflecting that you're bringing them along the spectrum, that you're bringing them from I have a life coach to I can work independently. Some people, I can tell you, and we have a lot of them, will never come off of that. They just don't. But for the vast majority, they want us to do it. But you have a caseload if they have chronic substance abuse or they have no life skills to where they can't live independently. They're still 50 years old and they live with their mother, and you have to not only tell them, remind them of their appointment, you've also got to call their mother. That's your first key right there, telling you those people are never going to come off of case management because they don't have the skills available in their life to live independently. And last are your comprehensive case managed patients. Those have the acuity scale of 37 to 54. Those are your people you're going to find that are in crisis in their life. They're homeless, they're actively on drugs, they may be pregnant, they may have APS or CPS involved with their life. You're doing intensive case management with them. I've gone as far with patients, I've had to call them every day just to remind them to take their medicine. Or you're following behind them to say, did you take a shower today? Do you have groceries in your house? Things like that. For those people, they are automatic. They get a case manager. They have minimum contact every 45 days to reassess the acuity. We have to document every interaction in ARIES, and then we also have to update the care plans. And again, for those people, you're going to take even further baby steps, where it could be where their need is, if it's medication adherence, you might be, like I indicated before, it might be call them on a daily basis to remind them to take their medicine. And then again, the active case management services are in your documentation. And so that's your follow-ups, constant follow-ups. So it goes. How many
managers do you guys have there?
I'm sorry, say that again.
How many case managers do you guys have there?
To be honest with you, right now we have 2 full-time and 1 part-time. She's here 2 days a week, and our caseloads are approximately 65 for our full-timers and 20 for our 2-day person. But I can tell you there's good days and there's bad days, but it is manageable. Because for the most part, you're going to have people you're case managing, but you're just bringing them along until you graduate them. It's your ones that are your long-term people, the ones you're really spending the majority of your time on. The others you're just touching base to say, okay, are you okay with your medicine? Are you having any side effects? Things like that. So it might be a 5-minute phone call, or you just checking behind to make sure they came to their appointments.
Okay. Thank you.
The next is open clients. We talked about those. Those are your people that it's been determined after they get that initial assessment, they are open clients. They're not case managed, but we are available to them. We can assist them, but when it comes under being billed, again, when it comes to Aries, that program, they're going to be billed under non-medical case manager. Even though the case manager may help them, what you're doing is you're helping them with things that are like a one-time thing, like, oh, I need to go to the dentist. Can you help me fill out my physician certification form? It's pretty much for HIV clients in our program, we send them up to Bering Dental in Houston, and for those people, we have to send their labs. So for them, I'm giving them non-medical case management. The difference between it is if at any time your people need medical help, like I need my doctor and I need him to change my medicine and stuff, if it's going to do anything that's going to take up your time more than a few minutes of you giving them help or explaining them what the donut hole is for Medicare, things like that. If it's going to take up a significant amount of your time because they're in a crisis level, you're going to need to call a halt to it and you say, well, wait a minute, I need you to come in and either one, get enrolled if they're not an enrolled client now, or two, you flip them over to case management. Because you're getting paid at a lower rate when you're having to bill under non-medical case manager. If you're having to really be their case manager, you need to make them case managed. Everybody okay with that?
Mm-hmm.
Okay, we talked about the case management acuity scale. Again, it is on the scale itself. It's the last page of it, so it is going to be your guidelines for all your patients. I know here, and this is something I have to give Melissa kudos to since we implemented this, because we just implemented this acuity scale at the beginning of this year. She's actually set it on, we use our Outlook, our calendar, Outlook, and she's actually set, so when she's doing her intake, she's actually putting in there on what day she needs to follow up, what her 90-day point is, so she's looking under her notes to determine, okay, if I haven't reached this patient by now, today's my deadline, just to make sure you stay within your dates. Under care plans, again, it's needs and goal-based. You don't want to make it too overwhelming for anybody. It's all baby steps just to get them through the spectrum, to get them to be self-sufficient. It addresses your 3 highest priorities when you establish the priorities under the acuity, and it requires update to the care plan for every time you have a follow-up with that client, because that's why you're following up with them to say, did you go to the dentist? Did you do this? Did you do that? Or you reporting to them what you did for them. Whenever it's an open client, that means they are not case managed. You do not have a care plan for those people. And I would highly recommend, we were caught in this before, I had care plans because I didn't have the option of having extra people. The care manager was doing everything. We were doing intakes, care managing, everybody. So I thought it was easier, and I had even care plans for open clients, and it worked against me when we were audited. So no, if they're not case managed, don't give them a care plan. Under 6 months attestations, this is under enrollment. So for the person who's doing your enrollment worker, the 6 months attestation, it's a 1-page piece of paper, and it is a short and sweet thing for the client to say, what has changed with me? And they're attesting that nothing has changed or things have changed. So what they're looking at is, let's see here, it goes by what's their name, what's their social security number, and then they want them to write what their newest address is, what their newest phone number is. And then you're also attesting, I have no income, my income has changed or it has not changed. If it has changed, which a lot of people do, either they've lost a job or they've gained a job or they're now getting SSI, they are required to bring in any updates on any of their information. So that means update to residency, phone, income, insurance information. Again, and if they've obtained insurance, then they have to report what insurance they have, and at all costs we will get copies of their insurance cards to make sure we're not still incurring the cost of their appointments. We have a lot of people, unfortunately, that even though they may have insurance, they are familiar with the Ryan White program, so it doesn't, their income in their mind does not matter as long as they can try and get what they can from the Ryan White program. That's why more and more it's becoming more restrictive where we're requiring all of these proofs. They will deny us payment if it's determined that we've paid the bill for somebody, and then we go to the state and say, you know, pay this bill, and then when they come and audit us, unfortunately, they're going to determine we may not have the proof. Say they don't live in our area anymore, but we're still paying their bill, or they have income and they fall over the guidelines, but yet we're still assisting them and paying their doctor visits. Therefore, they can reverse those charges and not give us reimbursement on that money. So this 6 month attestation is important in a lot of ways to get us to provide follow-up. It's also for anyone who is case managed at the 6 month point, we're required to do a comprehensive reassessment on the patient to see, do they still qualify for case management? Are they meeting their goals? Or has something else developed? You know, say they have a history of substance abuse, but now they've relapsed, and that is one thing you're focused on, because all of your follow-ups are focused on what their needs are at the time and what was established with the previous acuity, but you're establishing a new acuity and a new care plan and new everything with that client. And then again, if they're an open patient and if it's a 6 month attestation, they're an open patient, they're not case managed. If anything is triggered for our person, where they're asking, I need this and I need that, she is strictly black and white to where she is just doing enrollment and ADAP. If it comes to that, then a case manager, she will refer that person to us, and that's where we will either make the determination, yes, they need to be case managed, or no, we're just going to give them that non-medical medical assistance. Adherence, it's completed at the 3 and 9 month marks. The goal of Ryan White came about because it was to obtain medications for people who were not able to afford it. So in turn, one of the criteria is, and we'll talk about this under the quality plan, but under adherence, you're checking with your patients to make sure, and this is open as well as case managed, to make sure people are adherent with their medications, because that's the whole goal behind this. So we are looking, if you look at it at 12 months calendar, we put people on medication. That starts day 1. At 3 months, we're calling them, or within that month time frame, we keep a spreadsheet to say who's due for their adherence this month, and we are calling them. It does not require a nurse to do it, but someone in your organization needs to call and ask these questions, and we have a form that's provided. And what it is, are you taking your medicine over the last 7 days? What's your percentage of taking your medicine? Do you know, and you're asking them questions about their medicine, and in addition to that, you're asking them additional questions where, do you have anything else that you're concerned about or that you need? It's also a trigger if they need case management again. So we do that you're required to do it twice a year for all clients, so we do it ourselves because everyone is touched at 0, 3 months, 6 months, 9 months, and then again at a year. So at a minimum, all of our clients are, I know this sounds like a lot, but I promise you, you can do it. Okay. All clients receive referral to management as indicated, and again, everybody gets an adherence if they're receiving any Ryan White monies from your group. Okay, under ADAP, ADAP is a beast. Okay, our new people, we got new enrollment / ADAP workers this past year. I think they started maybe in October timeframe hiring people. If you don't have them on board yet, you will. I'm sure you will shortly. But what this person was hired, they were hired to strictly do ADAP. There's a lot of rules and regulations that come with ADAP, and it's limited. So your case managers are really have to step back and let the ADAP worker do their job, because more and more they're isolating it to where it's only going to be limited to where your ADAP worker is the one communicating back and forth with ADAP located in Austin. And ADAP stands for, let me see, AIDS Drug Assistance Program. It's also known nowadays, that's the old term for it, so most people call it ADAP, but the new term for it is called THMP, Texas
HIV
Medication Program. There you go. Okay, so you'll hear it by two different terms. They're located in Austin, and best way I can tell you is they get their money from the federal government, but it comes out of a different checkbook. But again, it falls all under Ryan White. Enrollment has to be completed with every client that we do ADAP on. Okay, it has to come from the ADAP enrollment worker. It used to be where they allowed people to just download them on off the internet, and you filled out your own form and sent in your stuff. But now it requires everything to go electronically. It has to be typed, and they're now creating a electronic program where the ADAP worker is just going to submit everything back and forth. I do know here is a new thing. Last week, our ADAP worker just went to Austin and got her education at the state level. And next month, I am her backup, the only other person here in our organization that's allowed to send ADAP applications, because they won't accept them from anyone else. I have to go to my required training next month. I believe that's the 18th and 19th. What's that?
Does that go through Aries?
No, ma'am. Aries is strictly about billing. ADAP is another organization at the state level, and it's strictly about HIV medication. That's why they don't allow it under LPAP. But it does not go under Aries. But you as a case manager are going to document ADAP was completed or ADAP pending, because that's part of your job, is you're following up to make sure that they get on medications.
Okay. But that's just a whole nother electronic upload to something else.
Now, they do give us the ability, and I'll share all of that with you when you come to visit, but I have all their workers' names and what they work on. So there's one person that's all she's dedicated to doing is taking care of recently incarcerated people. One is for Spanish speaking. One is for, one who needs to be expedited, okay? For people who need to be expedited, that means we're allowed to fax it in currently. And though it's a 1 to 2 week turnaround to get people approved for it. The only criteria it is to have that happen is their CD4 has to be below 100. For everyone else, everybody is different, but they process everything as they're getting them in, and on average, it's approximately a 90-day turnaround. So I can tell you my medical director, Dr. Philip Kaiser, he has discussed this with them at a lot of intervals, and unfortunately they said they are not an emergency medicine organization. They're for long-term chronic use, and that's why this 90-day is not going to go away anytime soon. They're working on it, but unfortunately you have to provide PAPs for people who you may need to get on earlier. Okay, the criteria for ADAP in the state of Texas, and again, every state is different. It just depends on how much money you get for your program in your state. Only people who fall below 200% of the federal poverty level qualify for ADAP. Now, there are criteria for people, say they're on managed Medicaid and it's not in their formulary, or they were recently let go from their job and they need assistance where they're picking up COBRA. Well, ADAP actually will pay for COBRA because it's been determined, along with Affordable Care Act, that it's much cheaper over the long term to care for somebody when they have insurance versus caring for them under the Ryan White program. So I hone in with every one of our patients. we are the payer of last resort, so we are required to refer you to every other organization and everything else we can get for you before we ever use Ryan White money. But again, ADAP will only accept people who are below 200% below the federal poverty level. The other one is annual re-enrollment is required. There are some issues with ADAP right now going on at the state level. It used to be, as of 6 months ago, it was where our clients were only required to re-enroll with ADAP every 2 years. It's now become where it is every 1 year. They've established two things with that. One is, as of last September, they started re-enrolling everyone in the entire state because of the issues that they were having at their end. Unfortunately, you do not know as a case manager unless you're tracking your clients when they're due for enrollment or re-enrollment. So the letters are only being sent to the clients. And unfortunately, the vast majority of my clients do not open their mail. So the only time that they know that they cannot get medication is when they go to pick up their medicine at the pharmacy and the pharmacy says, I'm sorry, your ADAP is not active. So then they're calling me in a panic saying, I cannot get my, I can't pick up my medicine today. What happens in that situation, it means they ignored their mail that was sent to them saying they were due for their re-enrollment from ADAP. So in turn, as a case manager, that is when I'm interacting with ADAP and I'm calling on the client's behalf saying, they're here with me right now and we're taking care of that re-enrollment. In turn, they will open them up for another 30 days and allow them to get 1 month of medication, but with the understanding that that client will follow up and complete their ADAP re-enrollment. And essentially all that is you're completing a new application for them and providing all the proofs to ADAP. I'm sorry, we're way over. Are y'all okay with this? Still going on?
Yeah, we're good.
Okay. PAPs are the alternative, the short-term fix to help people with people who need medication. HIV medication on average is anywhere from $1,500 to $2,500 a month per pill for a 30-day supply. So the two sites we go to are needymeds.org and then HarborPath. You're going to want to establish a contract with HarborPath and say for people who have, we would use this for people who have complex needs that aren't necessarily on the formulary that you can get them a PAP for. So not only are you getting them HIV medicine, but you may be getting them an insulin pen, or you may be getting them Restasis for their eyes, things that you can't get covered under the LPAP. HarborPath is a good site that you're going to want to contract with. It doesn't cost any money, but I believe they require a contract with your organization, a memorandum of agreement stating that you'll use them. You don't have to use them exclusively, but essentially what it is you're filling out the one-time application and then you're open to all the different medications that they offer for PAPs. PAPs are good anywhere from 90 days, they're approved, and PAPs stand for Patient Assistance Programs. Okay. Next. All right, the quality plan, and there's going to be a meeting. We're required to meet under the quality plan once a quarter, and I've sent a copy of our quality management plan to Cordella, and we have a meeting if anybody would like to sit in it. I think Cordella is going to be meeting with us, but under the quality management plan, we have to cover clinical indicators, which are over 90% goals. Programmatic indicators, again, we have over 90% goals we have to achieve. It also established our consumer advisory board where we report all of these indicators that we are measuring on a monthly basis to the consumer advisory board that you're going to have set up for your organization. And then we also review the complaint log. It's a short, sweet, it lasts anywhere from half an hour to an hour, but we have to meet on a quarterly basis, and we're required to keep minutes on it. We also talked about the expenditures of our grant funds. So our business manager that oversees that, she comes in and she talks about, you know, how much we're spending. Are we over budget? Are we under budget? For instance, this year we've had a case manager position open, so we had to get rid of those funds because we didn't spend it. Because again, at the end of the grant year, we're supposed to be at zero. Again, I sent a copy of it, but what we're looking at under our clinical indicators are the percentage of clients with 2 or more visits in a measurement year, what the percentage of clients were with 2 or more CD4 counts that were completed in a year, the PCP prophylaxis, the heart medication, and the viral load counts. Again, and under program indicators, we're looking, that's pretty much just numbers. How many clients are in our program, how many clients are, breakdown of how many is receiving medical case management, how many we discharge from our program due to non-compliance, how many referrals we provided, and you'll be able to pull all that information out of Aries to be able to run your quality management, because all that information, again, has to be typed into Aries, so you'll be able to run reports to get that information. Okay. Other than that, that's pretty much it. Any questions?
Probably, just not yet.
Okay. Again, we have documents, forms, everything to back all of this up, and we will provide all of them with you. Everything's pretty much electronic. There's a few things that are not, that you'll have to do hard copy, you know, handwriting in or recreate your own that you can type in, but for the most part, it's all click-in boxes. A normal time frame to spend with a patient for a new patient is approximately an hour and a half. For a reassessment is anywhere from 30 minutes to an hour, if that gives you any indication.
All of the stuff that you're going to provide us, does that include like protocols and competencies?
If you want, I didn't send it today, but I do have all of that. I have like the onboarding. There's classes through the state of Texas under case management. You're required to have 12 CEUs a year under it.
Yes, ma'am. If you could please send that as well. All requirements.
Yeah. Whatever you want, just make sure y'all bring a flash drive with you, because unfortunately every time I've tried to email to you, it says everything is too big to go through. So bring a flash drive, okay?
Thank you.
All right, thank you very much.